Hey everyone, welcome back to the channel. If you have watched our ABG Made Easy video, you already know the basics. pH, Rome, Winter's formula, NN gap, and so on. But today, we go to one level deeper. This video is for fellows, for senior residents, or anyone working in the ICU. Have you ever seen a patient in the ICU whose blood gas looks almost normal, but the patient is clearly getting worse? Or a patient where the NN gap is normal, but something doesn't feel right? That happens because the traditional model has limits, and today we are going to fix that. These are the topics we'll cover today. We'll take one step at a time, and I promise by the end of this video, you'll see blood gases differently. Let's start. Okay, the Henderson-Hasselbalch model. We all learned this in medical school. It is simple, it works for basic cases. But it has a problem. The problem is this: it treats bicarbonate as independent, as if bicarbonate tells you what is happening metabolically. But bicarbonate is not independent. Bicarbonate changes when carbon dioxide changes, even without any metabolic problem. Think about that. You put a patient on a ventilator, you change the CO2 setting. The bicarbonate changes, but nothing metabolically happened. So bicarbonate is a consequence, not a cause. Second problem. Albumin infusion and saline infusion do opposite things to pH. Albumin makes blood more alkaline, saline makes blood more acidic. The old model cannot explain why. Stewart can. Third problem, and this is the big one. In the ICU, patients have multiple problems happening at the same time, and these problems can cancel each other out. A patient with low albumin has a hidden alkalosis, decides their true acidosis. The numbers look normal, but the patient is sicker than you think. This is dangerous. Stewart's model solves all of these. Three independent variables control pH. 1. Strong ion difference, SID. 2. Total weak acids, ATOT. 3. PCO2. Hydrogen and bicarbonate are determined by these three. You cannot change pH directly by changing bicarbonate. That is the key concept. And let that sit for a second. Okay, let me build this model for you from scratch. Think of pH as the output. It is the result. Three things go in and pH comes out. Input number 1 is strong ion difference, SID. Strong ions are sodium, potassium, calcium, magnesium, chloride, lactate. They fully dissolve in blood. Their net charge creates an electrical gap, normal SID, which is equal to 40 to 42. When SID goes up, pH goes up. When SID goes down, pH goes down. So when you give a patient a lot of saline, the chloride goes up, SID goes down, pH goes down. That means acidosis. That's why saline causes acidosis. Input number 2, ATOT, total weak acids, mainly albumin phosphate. We'll spend a full slide on this. And the last input is PCO2, and you already know this one. Now the key concept again. You cannot change pH by directly changing bicarbonate. When you give sodium bicarbonate to a patient, it works, but not because of bicarbonate. It works because of the sodium. The sodium increases SID and that raises the pH. Yes, the bicarbonate in the sodium bicarbonate is not the active ingredient. The sodium is. Isn't it mind-bending? Okay, two versions of SID. Don't worry, this is straightforward. First, apparent SID, also known as SIDA. This is what we measure from blood test. SIDA is equal to sodium plus potassium minus chloride minus lactate, and normal value is 40 to 42. Second, effective SID, also known as SIDE. This is how SID is buffered in plasma. It is given by the formula SIDE is equal to bicarbonate plus albumin plus phosphate. So in a healthy person, SIDA and SIDE are both about 40. They match. Now the strong ion gap or SIZ. SIZ is equal to SIDA minus SIDE, and normal SIZ is equal to 0 to 2. When SIZ goes above 2, there are hidden anions in the blood. Things you cannot measure on basic panel like ketones, toxins, uric acid. This is like the anion gap, but smarter. Here is why it matters. In very sick patients, albumin is almost always low. So the low albumin makes the regular anion gap look falsely normal. A strong ion gap, SIZ, corrects for this automatically. So SIZ catches hidden anions even when the regular anion gap misses them. And this is very important in the ICU setting. Okay, this slide. This is where most trainees have their biggest light bulb moment. So pay attention. Weak acid, ATOT, is given by the formula albumin into 0.123 plus phosphate into 0.309. And albumin and phosphates, these are your weak acid buffers. So when albumin goes up, more acid is available. More hydrogen ion is produced, and the effect is acidifying. Similarly, when albumin goes down, less acid is available. There will be fewer H plus ions. The effect will be alkalizing. Low albumin causes a metabolic alkalosis. I know that sounds wrong. Let me show you why it matters. Take an ICU patient. Albumin is 20, half of normal. Bicarbonate looks like 22. pH looks like 7.38. You think, okay, what's wrong with that? It's everything looks normal. But Stewart says the low albumin is creating a hidden metabolic alkalosis of 5.5 milliequivalents per liter. Without that hidden alkalosis, the pH would be significantly lower. The patient is much more acidotic than the numbers are showing. The low albumin is actually hiding the truth. And almost every ICU patient has a low albumin. So always calculate this in every patient, every time. Delta base excess albumin, which is given by the formula 0.25 into 42 minus albumin in gram per liter. So if albumin is 20, delta base excess is plus 5.5. Hidden alkalosis masking acidosis. It's simple, powerful. Do not skip it. Okay, this table is a summary. Every metabolic acid-base problem now has a mechanism. So when sodium increases, SID goes up, and that leads to alkalosis. When there is chloride excess from saline, SID goes down, and that leads to acidosis. High lactate, SID goes down, likely acidosis. Low albumin, ATOT goes down, hidden alkalosis. High albumin or dehydration, ATOT goes up, acidosis. Hyperphosphatemia from kidney disease, ATOT goes up, acidosis. Unmeasured anions like ketones, SID goes down. High anion gap, acidosis. Notice the pattern. Every acidosis either decreases SID or increases ATOT. Every alkalosis either increases SID or decreases ATOT. That is the entire framework in 2 sentences. Okay, let's go to the clinical tool. This is the most useful part of the entire lecture, the Fencl-Stewart approach. It takes Stewart's complex math and makes it bedside friendly. Base excess is equal to base excess sodium chloride plus base excess of albumin, base excess of lactate plus base excess unmeasured. For components, you calculate each one separately. Take about 2 minutes. This is only standard blood test. Let's go through each one. Component 1, NaCl effect. So delta base excess, NaCl, is given by the formula sodium minus chloride minus 38. Normal sodium minus chloride is 38. If the answer is less than 0, chloride is too high. which is hyperchloremic acidosis, which occurs almost always from excessive saline. If the insert is more than 0, chloride is too low and leads to hypochloremic alkalosis. And the example is vomiting or use of any diuretic drugs. And this one calculation tells you immediately if your team has given too much saline. And the component 2 is albumin effect. So the delta base excess albumin is given by the formula 0.25 into 42 minus albumin in gram per liter. So from the above formula, we know that if the albumin is low, the result will be positive, which means hidden alkalosis. Component 3, it is lactate. So delta base excess lactate is equal to negative of lactate value. So lactate is 4 contributes to the -4 to base excess. Component 4, unmeasured anions. Take the measured base excess and then subtract all 3 contributions. And what is left over? Those are unmeasured anions, that is ketones, toxins, or uramic acids. 4 components, 2 minutes, clear picture. Let me show you how it works on a real patient. Okay, real patient, real case. 6-year-old child with diagnosis of septic shock, and today is day 3 of PICU admission. In blood gas analysis, pH is 7.28, that is acidotic. CO2 is 32, child is hyperventilating. Bicarbonate is 14.5, which is low. Base excess is -12. Sodium is 138. Chloride is 115. Albumin is 20, and lactate is 4. So let's do the traditional analysis first. So the ABG picture shows metabolic acidosis with appropriate compensation. And if we calculate NN gap, which will be equal to 8.5, which is normal NN gap. So traditional analysis is move on. But wait, when you correct the NN gap for albumin, it comes out to be 13.5, which is high NN gap. That means there are unmeasured anions. Now let's calculate by Fencl-Stewart approach. So let's calculate the first component in HCl effect, and it comes out to be -15. So -15, that is a massive hyperchloremic acidosis, which occurred due to our saline. And someone gave this patient a lot of normal saline. And the second component is albumin effect, and which comes out to be +5.5. So the low albumin is creating a hidden alkalosis of 5.5. It is masking the true severity. Without it, base excess will be -17.5. And the third component is lactate effect, which is -4. Now let's calculate unmeasured anions. And it comes out to be +125, which is essentially 0. So that means it has minimal unmeasured anions. There is no hidden ketones or toxins. So the question is, what is driving this acidosis? It is not ketones, it is not uramic anions, or it is not primarily the sepsis. It is due to saline. So the biggest driver of this patient's acidosis is the saline your team has been giving for past 3 days. So what will the treatment? Simple. Stop normal saline and switch to lactative trainers or plasmolite. You cannot reach this conclusion with traditional bicarbonate analysis alone. And that's the power of Stewart approach. Okay, triple acid-base disorders. It sounds complicated, but it is actually very simple. You can only have one respiratory disorder, but you can have 2 metabolic disorders. So the maximum possibility will be 1 respiratory condition plus 2 metabolic conditions. And that leads to triple disorder. So for example, in type 1, you can see that there is respiratory acidosis plus high NN gap metabolic acidosis plus metabolic alkalosis. And the clue will be delta NN gap or delta delta gap, which will be greater than 2. The NN gap is high, but bicarbonate is also high. So there is something keeping bicarbonate up, and usually that will be by diuretics or due to vomiting. And the example will be COPD patient who has decay, who is also on furosemide for years, and the patient has three disorders at the same time. And next one is type 2. So it will be respiratory disorder plus high NN gap acidosis plus normal NN gap acidosis together. And the clue is again delta delta gap, which will be less than 1. So in this condition, bicarbonate has fallen more than expected. Something else is also consuming bicarbonate, and that will be usually due to excess saline or diarrhea. And the example will be septic patient with lactic acidosis plus very high volume resuscitation by saline, both happening at the same time. So how to detect the triple disorder? Step 1 would be correct NR gap for albumin. Step 2 will be calculate delta delta or delta NN gap if NN gap is high. And step 3 will be, if you are still confused, run Fencl-Stewart approach. Now let's talk about 5 scenarios everyone working in ICU should know. Scenario 1, decay. At the start, there will be high NN gap acidosis from ketones. You give normal saline to treat. The ketones clear. The NN gap closes. But now the saline creates hyperchloremic acidosis. The patient hasn't recovered. One acidosis is replaced by the other. Always track the delta NN gap during treatment. And once ketones are clear, switch to balanced crystallite solution. Scenario 2, salicylates toxicity. So in this case, two disorders happening at once. Salicylates, they stimulate brain, causing respiratory alkalosis. And there will be salicylates anion accumulation, causing high anion carb metabolic acidosis. Early on, these two cancel out, and pH looks almost normal. But CO2 is low and anion gap is high. That's not compensation. That is two disorders. So think salicylate in any young patient with respiratory alkalosis plus elevated anion gap, especially with tinnitus or confusion. Scenario 3, chronic kidney disease. In case of aortic CKD, there will be normal anion gap acidosis. Kidneys cannot excrete ammonium and they reabsorb chloride instead, leading to hyperchloremia. In later stage of CKD, when GFR fall below 20, sulfate, phosphate, and hippurate accumulate, leading to increase in NN gap. Hyperphosphatemia also worsens acidosis by ATOT. In case of CKD, there will be normal NN gap acidosis in the early stage and higher NN gap acidosis in the later stage. As CKD progresses, the pattern changes. Scenario 4, liver failure. Two forces fighting each other. One will be alkalizing forces, low albumin, low potassium, vomiting, diuretics. And the respect, there will be acidifying forces like lactic acidosis from impaired liver function. And they cancel each other. pH looks normal, bicarbonate looks normal. Traditional analysis is no problem. But there are two big hidden disorders underneath. Normal numbers in liver failure are a warning, not reassurance. And the last scenario, massive transfusion. 3 things to remember. 1, cited in blood gas binds calcium. Ionized calcium drops, and so always monitor it. 2, cold blood causes hypothermia, and oxygen doesn't release to tissues as well. And number 3 is large blood volumes create dilutional acid-base changes. Use Stewart approach in massive transfusion. It separates all 3 effects cleanly. Okay, let's bring everything together. 10 steps, use this every time. Step 1, look at pH. Is it acidemia, below 7.35, or alkalemia, above 7.45. Step 2. Do you get CO2 and bicarbonate? Which system is the primary problem? Always use Rome. Step 3. Is the compensation appropriate? Use Winter's formula or the 1425 rules. Apply the physiologic limits. Step 4. If pH looks normal, but CO2 and bicarbonate are both abnormal, do not stop. There is a mixed disorder. Step 5. Correct the NN gap for albumin. And do this for every patient, every time. Step 6. If NN gap is elevated, calculate delta NN gap. Step 7. For complex ICU patients, run Fencl-Stewart approach. Step 8. Always calculate AA gradient. Step 9. If normal NN gap stenosis, calculate urine NN gap. If positive, RTA, kidney problem. If negative, diarrhea, gut problem. And step 10, the most important one, always clinically correlate. The blood gas is one piece of information. And in front of you is the full picture. These are the numbers you need to know. Screenshot this, save it on your phone, use it at the bedside. And that is the advanced ABG lecture. So your next step is simple. Take your next ICU patient, run Fencl-Stewart approach, calculate SIG, and you'll see things in the blood gas you never saw before. And if this helped, please like and subscribe. Share it with your friends. Drop questions in the comments. See you in the next video.